T.H. Chan School of Public Health, Dr. Pooja Kumar, a senior partner at the McKinsey Health Institute, and our moderator, Foreign Policy's Allison Carlson.
Great, thank you so much for joining us this morning, and we really get to build off of an incredible conversation about caregiving to dive deeper into issues pertaining to the workforce. We all know there's already a tremendous healthcare worker shortage around the world, exacerbated by COVID-19, and healthcare workers are facing a number of challenges, from conflict to financial pressures to individual stress. And we need to shine a greater light on them here and what can be done to address it. You know, the WHO is projecting a healthcare worker shortage of 10 million in the next 5 years. And that level is likely higher. And so picking up on sort of the theme of how we can understand how the workforce shortage is having an effect on the ground and having an effect on healthcare delivery, Minister, I'd like to turn to you first. You know, many countries around the world are facing an acute healthcare worker shortage. And I'm wondering how that's manifesting in your country and how you're seeing that impact both healthcare delivery, but also patient outcomes.
Thank you so much. Let me take the opportunity just to thank the organizers for inviting me, just to share how we are doing in Malawi. It's a great privilege and an honor. A very good question, which would take me like maybe a whole day just to sit here, so that you can get a clear picture. But I will try my level best to tackle it in a few minutes, which I have. The situation in Malawi, I should say that we are coming from a position where you already have a very high vacancy rate. What I mean is that where you needed to have 10 or 20 nurses, maybe you only have 40%. So that is the situation where you're coming from. So there are a number of issues which really they're putting more pressure on the situation which was already dire. We've been talking about the impact of climate change. I'll give an example of Malawi. Malawi, we have had the cyclones for the last 4 years, which brought about an outbreak of cholera, the worst cholera outbreak we have ever had in Malawi. We lost over 1,000 Malawians to cholera. So when you talk about cholera, because maybe for most of us here, we are really not aware of what we talk about when you say cholera. Cholera, it's an outbreak where the patient is purging, they're vomiting. You really maybe need 2 health workers for just 1 patient. So you can imagine if you have hundreds of patients, how that puts so much pressure on the system in our hospitals. So these issues, the issues of climate change, they're putting in so much pressure. And then we have re-emerging issues. We had polio, we had measles. So you make progress, but then you have one crisis which sets you back 10 steps. So that really is also having an impact. And of course, we cannot not mention the elephant in the room is the withdrawal of aid, which really has also affected us. For Malawi, I think we have lost about 5,000 healthcare workers across the country, and to us, that is too many. 5,000, and just like that, when we really didn't have any plans at all. So that is the situation. And of course, it's not like we don't have trained nurses, trained clinicians. We have them. But now it's the tight fiscal space which you have to work with. It's very tight. We cannot afford to recruit everyone we need. They are available. So now what we are trying to do is, because now we have to integrate most of the services, HIV services, malaria, tuberculosis, we have to integrate with everything else, and because now you cannot afford to have a vertical program, which is the situation. We have to be realistic. Now we have to just to see how best we manage. So because of integration, now we're trying to see, putting so much on one person. Now we're saying, no, let's just look at the woman, whether she's HIV positive, or whether whatever. Let's just look at the woman, this woman, what does she need? A child, what do they need? So this is what we're trying to do now, so that we can see how best we manage. The other thing which also I think was a problem is that you would have a partner coming to assist you, but they will not have a human resource component. They'll have all these nice things, want to strengthen, but they have got their own idea of strengthening your health system, which we are saying, no, it should not be like that. I know how to strengthen my health system. I already know where the gaps are, the challenges are. So if you want to assist me, you can, but use our plan, the one plan which we have as a country, because we already know where the challenges are. So that is what we're impressing on all those who want to come to Malawi and assist us, so that we work together. I think the other issue was that, also most partners, they will come in, but they will pledge something, but then you cannot follow it up, which I think was also putting us in problems. What they say, no, we have given Malawi 20 million. You ask, that 20 million US dollar, where did it go? Maybe half or 3/4 of it went back, or they had a very expensive consultant, which I didn't need. So these are the real issues which have been on the ground. But we're saying, let's simplify things. Let's simplify. We already know what we want. I want a health post. I want a nurse. I want a commodity. That's all. Strengthening, to me, it means that. Let me stop there. Thank you.
Thank you, and thank you for that. And Dr. Carey, I saw you nodding your head through much of what the minister was saying, and I'd like to follow up with you, as the WHO Special Envoy for Climate and Health, and also your work with Seed Global Health. I'm curious, from your perspective, what are you seeing as some of the most pressing gaps as far as the healthcare workforce shortage and areas that really need to be addressed in this acute situation that we're in?
It's a terrific question, and I just want to start by thanking Foreign Policy for pulling together a really important conversation and for leading forward to cross sectors on the importance of health. Very privileged to be here with my colleague, Pooja, who I trained with, so it goes way back, and incredibly honored to be with you, Minister, because you have been a leading voice on holding us all accountable to what this moment, to what's been happening, but also what the moment can bring. And I think, so in answer to your question, we know there's a global shortage of healthcare workers, but there's also shortages of different kinds of healthcare workers, multiple kinds of healthcare workers across the board, and the distribution of those healthcare workers is very off too, right? So they tend to be in urban centers, they tend not to be in rural areas. There's often a concentration of specialists in the private sector, but those are not available in the public sector. And so we are looking at a continued shortage of healthcare workers, but we're looking at a shortage of healthcare workers that I think, when you look at the number, it actually underestimates the crisis. Because we're living in a time right now where climate change is accelerating all of our health threats. Climate change is completely agnostic to what disease it wants to affect. It will drive our vector-borne diseases. It's going to drive our non-communicable diseases. It drives maternal health burdens, mental health burdens, trauma, accidents, all of it. And so when we're looking at cholera, as we heard, so the reality is the workforce is going to be under more pressure to manage more disease, under more pressure to know a broader range of diseases as these diseases move and shift, right? So in the United States, where I'm from, we now have malaria, and we're going to see dengue, and we're seeing new diseases and things that we're not used to, and so everybody's going to have to get trained on what the shift is here. But we also just need more numbers in the setting of this evolving, pressures that we're seeing today. And so, Seed Global Health, the organization that I run and have the privilege of working with Minister Chipanda in Malawi, what we're seeing is that we need to be very strategic about the kinds of healthcare workers that we're investing in and how we're building out a healthcare workforce that is fit for purpose for the disease burdens. So our first approach is to ask the minister, what are your priorities? So for example, it is family medicine, because family medicine physicians can take care of 70% of the health problems that we see within the community. So that's a powerful investment that allows us to be responsive to what we see in climate and health, allows us to respond to pandemics, allows us to support a cholera response. But for us, it starts very much with the national plan and how we can fit and support that national plan as we move forward. The US just cut 42% of foreign aid globally for health. The UK followed suit, which was the second highest country providing aid at 12% of foreign aid, and they're now dropped. And most of Europe is actually reducing its aid, which means there's a profound fiscal austerity that is happening right now. For the workforce, we already faced a crisis where people felt like there was not the ability or the domestic financing pathways to support workforce regularly, hence often needing the vacancy. But why is that? That is because the external stakeholders, and many put concessions on loan or put certain loan conditions such that Africa spends more servicing its debt than it does on health in the continent, which makes it very difficult for a country like Malawi to hire a workforce based off domestic budgets and to sustain it long term. And so what we're facing is a moment right now that I really want to underscore is going to require a very pragmatic and different way of investing in health, and is going to require one health plan, one budget, one set of metrics, and a country-led approach that we all get behind. And I really am grateful for the leadership that the minister has brought forward to that, but it's going to be the only way for us to think about how we reduce duplication, reduce the administrative costs, and get really thoughtful about how we start to build a healthcare system that can respond to all the challenges that we're seeing, founded on a workforce that brings that flexibility, and in a way that we're also forcing and engaging external stakeholders to understand the need to create the fiscal space for that path. And finally, we can talk about this later, why these investments in health are not costs, but actual investments in economic growth and security and in a sustainable system for health.
Thank you for that. I think that point is really important, is to reframe this whole conversation about investment rather than cost, especially when there are very tight fiscal space, limited budgets, et cetera. And I want to come back to some very specific mechanisms for financial support, both in the short term and the long term. But I'd like to pick up first on something that you said about how the number is likely underestimated and not completely known, but also differentiated around the world. And I know at McKinsey, you've done some great research on this specifically, and the Health Institute has recently released a report showing how the manifestation is different around the world. And I'm wondering, in terms of numbers, how you could describe some of the insights and how we can use some of those insights to inform our actions more precisely and in a more targeted way going forward.
Absolutely. And thank you for having me. It's rare to sit with a group of folks where I just feel such common cause with this topic. I've heard the number 10 million thrown around a lot today, and that is officially, I think the WHO has that as its predicted number of shortage of healthcare workers by the year 2030. We, as Allison just said, just last week released a comprehensive report on this topic and added a few more numbers to help really not just size what we see and feel every day, but also try to frankly raise the urgency around this topic. So let me give you a few more numbers. 10 million, first of all, is in the range of estimates, but if you look more broadly, there's a whole range of estimates that academia, think tanks, others have put out there that range between 10 and 80 million, if you truly look at the fullness of the full healthcare workforce out there. And Vanessa, you spoke a bit about the fact that we're not just talking doctors, right? We're not just talking nurses. We're talking about the full range of folks that are truly required to treat and prevent further progression of disease. So 10 to 80 million is the shortage. What does it mean? What would it mean if we actually closed that gap? Okay, so we tried to look at it from two perspectives. From a human life perspective, what would that mean? If we closed that gap, that would result in 189 million years of life saved or due to either preventing death or early disability. Okay. That equates to 7% of the total global burden of disease today. So imagine it's roughly equivalent to eradicating all of maternal and neonatal disease. I just want us to sit with that for a moment for any of us who's experienced, experienced either in our clinical care or through a family member, one of those conditions, right? Imagine if that just didn't exist. The second number, I'll put it out there, is frankly in financial terms. So if we actually were able to close this gap in healthcare workers, that would also increase productivity of the global workforce, equating to $1.1 trillion added to the economy. Okay, that is essentially equivalent to the entire economy of Switzerland, where we're all sitting today. And I say this not just to throw out big numbers, but because the case is just frankly unmistakable, right? Not only is it the right thing to do, but it's also the productive thing to do for economies. And there is a lot of data out there about how to do it, but McKinsey Health Institute, which I have the pleasure of leading, was founded on the premise that we are living in an age where if we choose to do so, we can actually add more years to life and life to years. One of the prior panelists said it. This is not magic, right? We know the solutions out there. It is actually about finding the right solutions for the right local context and the right national health plans, and then frankly, scaling those solutions. And it is a problem in every economy that we look at, right? I live in the US, I'm lucky to do that today. But if you look at rural America versus urban America, you see many of the same problems that you would see in other countries like Malawi, for example. And it is truly a universal issue for all of us to grapple with. I think the last thing I'd say before passing it back is this is also not a problem that the healthcare sector is going to solve alone. It is impossible. And as all of us who've grown up in healthcare know, we feel it, right? We feel it every day. We feel the pressures on the staff that we work with. And we've also tried, I think, for decades, some of you in this room, to address this alone. This has to be private sector, public sector, ministers of health, ministers of finance, the whole range of stakeholders that touch this space have to come together to solve this problem.
Thank you for providing some more context and regional differentiation and the numbers that are affecting people's lives every day. And like you said, this isn't magic. So how do we do it? And I'd like to turn to some very concrete nuts and bolts solutions and ideas for financing. We're in a situation of, again, tight fiscal space for a number of reasons. And so what are some concrete ideas that are actionable now to really address the acute shortage of healthcare workers in Malawi? And then, Dr. Carey, I'd like to turn to you from your perspective.
Thank you so much. So what we have done in Malawi, we also launched our own health financing strategy. And we launched that, I think that was 2023. It's not a new problem. It has always been there. We cannot have enough in our kitty. So we're saying, okay, what is the best way, for us to put a little bit more? So we launched our own health financing strategy, and this one we're trying to do what she was saying, that we need to involve the private sector, other organizations, so that we can work together, to bring in. We're encouraging public-private partnerships as well, to make sure that we try to fill the gaps which are there and, to address challenges. So that is going on well, but also integration. Integration is one way of, bringing more efficiency. And because we had so many duplications, you can imagine at one point in time, in the Ministry of Health, we have over 150 partners, and then you have an agreement with each and every partner. You have a strategic plan with each and every partner. We were overstretched as a ministry because we have to work with so many, partners. So that was bringing duplications and wastage. So having one plan is also one way of reducing wastage and duplications, Unfortunately, we are still meeting resistance because, like I said, some other partners, they're not flexible. because they had preconceived ideas when they're coming to Malawi. We want to do this, we want to do it our way, and not the Malawian way. And so we still have some other partners really resisting. They just want to do it their own way. But see, like now what has happened with PEPFAR, because PEPFAR, it was just about HIV. But we said, no, this woman, you have invested millions of dollars to save from HIV, but we are losing that patient to cervical cancer. I have a high burden of cervical cancer. How many partners are interested in cervical cancer? Very minimal. I have huge problems with mental health. We all talk about mental health, but ask me, how many partners are interested in addressing issues of mental health? None, none. So you save this child from HIV, AIDS, whatever, but you're losing them to these other issues, NCDs. And now, because somebody's talking about NCDs, we all talk NCD, we have to do something, NCDs. But how many are prepared to come say, okay, NCD, what do you want to do? We want to do ABCD. Okay, we're going to give you resources. Very minimal. So these are the real issues which are on the ground. So doing integration and having one plan is one way of making sure that the little which we have, but we use it prudently, but also make sure that we also address these other issues which are equally important to the people of Malawi. Thank you.
Thank you. Actually, several of those themes came up in our previous conversation on caregiving about system integration, reducing redundancies for greater efficiency, cost savings, but also to have greater impact throughout the life course, right? And so, Dr. Carey, I'd like to turn to you, picking up on the minister's comments, and when you're thinking about addressing acute care, but also building the workforce pipeline, what needs to be prioritized?
Well, I think, at Seed Global Health, we have always been working in partnership with the governments and the countries where we're invited. And so as we work alongside them, we found is that the priorities are to provide the kind of services that the minister described. I will never forget, we were at a forum together and someone asked you, what is your pandemic preparedness, your climate and health resilience? And your response was, it is primary care. It is family medicine. It is the nurse, the doctor, the community health worker who can manage the cholera, who can manage malaria, who can treat HIV, who can cover all of it. That is what the resilience is that we see. And I think that's the approach that we very much have taken, is that if we can think strategically about how we can empower a health system. Now, I firmly believe that the workforce is the leading edge of a health system because they are responsive, they can triage what investments need to come in, and we've seen that time and time again as we have done our work. That's important, but a resilient health system is one that is able to be responsive to all the disease burdens, one that can be responsive to the emergencies that we're seeing. And I think we're living in an era where we're emerging from an era where we've consistently spoken about HIV, TB, malaria, maternal health, NCDs, mental health, climate change and health, as though these are independent vertical issues. They're all so deeply intertwined. And so the opportunity that we have right now is to realize that a pandemic preparedness agenda is a climate and health resilience agenda, is going to address our NCDs, and to think in those integration terms off the bat, which then means that funders have to come in and give up a little bit of that, I have to have this metrics measurement on this time. Give up a little bit of that power and discover that really we don't have a choice right now. We do not have a choice but to get truly transformative. And to really, and the idea would be, if you do a single health plan and you bring a single funding pool together, and you get ministries of finance, you get all the ministries aligned, ministries of development, ministries of energy, and all these things that are aligned together to create this streamlined health system, what you're going to see actually is a healthier population that goes to work, earns more wages, you build a tax base, you have more economic growth, you have more security, you're likely to have less out-migration, more private sector investment, and there are case studies of countries that have done this. So there is an opportunity right now to do this whole of health system approach and to work very carefully with external stakeholders around financing solutions. There is no way to help countries move towards domestic financing without creating some, you do need an influx of capital to some degree, and you need a plan to taper off that capital over time that draws on special drawing rights, debt for health swaps, thinking about debt relief and aspects like this, private sector investments that can come in partnership, health insurance schemes for UHC. We have all these tools. We've just never been bold enough to design it into one system and to try to go forth. And I think that is what this moment requires. And we, I think, are going to try to go do this and together and to bring this forward. And there's a lot of discussions at the table. But we have to think very, very differently than we did before. And we can't recreate the same system just with some tweaks on the side. We have to realize fundamentally that health is an investment. Every country deserves the right to health. And that we, as an international system, have to get behind country-led plans, because that is how it will be sustainable, that is how we will be really responsive to the context, and that is how we can ensure that we can really deliver more services in a high-quality way and meet the urgency of the moment and the challenges we are facing.
Very well said. And you're talking about a transformative opportunity here. And I know, Dr. Kumar, in the work that you've done, part of your report is talking about reimagining training and being transformative. And so I'm wondering if you could shine a light on a few of the examples, a few of the case studies of what's working well, examples from around the world where you're seeing this in practice.
Yeah, absolutely. And I think when we step back to say, what can we actually do about this problem? Again, we tried to tie it back to the numbers and said, okay, let's imagine it's a 10 million gap, right? What would it take to actually close that gap? And what we found was that you can actually only close about 60% of that gap through supply, what we call supply side intervention. So, training more healthcare workers, reimagining training. The rest of that gap, we're never going to get there, right? It's training takes too long. There's too much to do to actually get to the skill level that you need. So the rest of that gap really has to be filled through demand side interventions. How do we reimagine people accessing their own, treating themselves, right? What would it take for the patient to become their own healthcare worker to some degree, and frankly to prevent disease from even needing a healthcare worker? And I say that because, to me, that is an important kind of mindset shift that we need to start thinking about both pieces of that puzzle equally. So when we think about the supply side intervention, I think it is very much around three things. How do we grow? How do we grow the workforce? How do we help healthcare workers thrive in their roles? And how do we retain them? And there are a host of examples I could give you across any of these, but maybe just one or two to help kind of color in the dots here. One, I would say, comes from Brazil. And we have a lot of examples, I think, of trying to scale up the number of training programs that are out there, and on every continent, actually, you can find some. So Brazil set out in 2013 to say, how can we not just say, let's just build one more medical school and try to get like 100 more doctors out there. But they actually, between 2013, I'm looking at my notes to make sure I get the numbers right here, 2013 to 2023, added 160 new medical schools across the country, okay? And Brazil is a very large country, but again, I want to kind of shift the mindset here to what would it take from celebrating opening one school to opening 160, or what would it take to open 500, right, across the country? So this expansion helped increase their primary care workforce by 12%. And when folks have looked back at the potential impact of some of that, we're looking at the range of about like 1 to 2 percentage points on mortality that could have prevented. And that is the sort of bold supply side intervention, and actually more than that, I think, that's needed if we really want to close the gap. And obviously that's a very physician, high specialist, right, view of things, but we are talking primary care. What would it take to kind of look at similar scale-up numbers for community health workers, for folks who live at, the last panel talked about family healthcare workers, right, to train some of these folks so that we can actually think about a comprehensive solution. One other supply side example I'll give is on training, reimagining training. How many of you are a healthcare worker of some sort, right? Many folks in this room. How many of you think that every day of your training was so productive and useful and directly led to the care and work that you give today? Right. So I say this because obviously I think we all look back very fondly on our training days. But, you know, I think times have changed, right? And we know a lot more about adult learning, frankly, now than we did 10 years ago, even 5 years ago. And there are a lot more technologies available to us today. So one example, again, is virtual reality. So the Purdue Global School of Nursing started a VR experiment in 2020 looking at how to actually use virtual reality to augment training and close gaps to licensure. So this is for folks who are already in the pipeline. And they were able to increase licensure certification by 10% by using VR for procedural training for nurses. And this is a high-tech example, again, but if we truly want to think about scaling up the full range of workers globally, we are going to have to look at solutions that are a whole set of solutions, including some of these types of things, to say we just don't have a choice anymore to say everyone has to go to a building, everyone has to sit in classes, everyone then has to learn on real patients, like very methodically, and we need to start opening our eyes to new solutions.
To close us out, because we're just out of time, is thinking about those solutions and what can and needs to be done. You know, training, supporting, and retaining workforce, healthcare workers around the world is incredibly important, especially when there's growing competition for workers. And when you think about that and think about what needs to be prioritized this week, Dr. Carey, and then Minister, to you, what are your calls to action?
My call to action is when you invest in Africa, you are investing for the whole world. There's no continent where you not meet an African. Most of the hospitals, you meet our people. If there are healthcare workers who are more dedicated, who are more resilient, and more committed and compassionate, the African healthcare workers. So let's invest in Africa. You are investing for the whole world. Thank you.
I would say we're all engaged in health, or we wouldn't be here in Geneva at the World Health Assembly. But we have a really important mandate to actually take this conversation outside of this community and make sure that the urgency of this moment for investing in health is understood by folks who are in finance, folks who are in politics, folks who are in the private sector or running businesses, because health is undermining each and every one of these things. The US is spending $800 billion right now in lost productivity and lost wages that are happening from health impacts from climate change. That's real if you're the CEO of a company. We have to be able to shift the urgency of what we're doing and the importance of the investments we're asking for into terms for those that can help mobilize the resources, the understanding, and the prioritization. And I think that's something we have not done enough of for too long. So my call to action is think boldly, think creatively. Understand that the health of people in Africa or anywhere in this world is going to impact the health of you and others around you. And therefore, we have not just the moral responsibility, but fortunately, we'll do the vested self-interest for those that need that argument. But we must take these conversations and the evidence outside of just our community and think very creatively how we have others understand the urgency of health, especially in this moment.
Very well said, and we all have a role to play. So thank you, Dr. Kumar, Dr. Carey, and Minister Chaponda. Thank you for being here.
Please welcome Amar Ali, the CEO of Vestergaard, Professor Samuel Kaba Akoria, the Director General of the Ghana Health Service, and Dr. Philip Welkoff, the Director of the Gates Foundation's Malaria Program, and moderator Dr. Maisha Alam, the Senior Vice President of Research at FP Analytics, for a conversation about eliminating malaria.
Hi, everybody. Thank you so much for joining us here in person in Geneva, as well as to our global audience around the world. I'm really grateful for the opportunity to have this conversation with such a diverse set of panelists. And we're going to be talking about the eradication of malaria. And I'd love to just dive right in, Amar, and begin with you. Vestigard is on the front lines of a lot of innovation and action as relates to malaria prevention and treatment. So start us off by setting the scene a little bit. How far have we come, and how far do we still have to go?
Yeah, thanks, and hi, everyone. I think when I look at the kind of history of malaria control and the path towards eradication, probably since the year 2000, we've had kind of three phases. The first one was of really, I would say, vertiginous progress, in the right direction. As the global health community got itself together, a lot of the institutions we see around the table today kind of coalesced and started to really function. Companies like Vestigard and many others started innovating to products to reduce malaria. And that went on for about 15 years, from about 2000 till about 2015, with, I think, about a 60% reduction in deaths, about a 40% reduction in cases, all of this in the face of increasing population as well. So, really incredible success, and really showed that malaria could be the next big global health success story, after a smallpox even, or even more than a smallpox. We then started to see a bit of a leveling off, though. And this happened in a lot of other verticals, by the way. I spent a lot of time looking in the world of maternal and child nutrition, and we saw a similar thing there. So there's a lot of kind of external factors around this, but some were also to do with what was going on within malaria, insecticide resistance being one. So we see a kind of leveling off the last the few years, kind of late 2010s, early 2020s, through COVID as well, didn't help, of course. And then we entered a third phase, maybe the last year and a half ago, where we saw new tools being introduced. Frankly, it would have been great if they'd been introduced a few years before, like dual active ingredient nets, which have been deployed for the first time in large scale this last year and a half. And those tools, in the particular case of dual active ingredient nets, can bring down malaria cases 65 to 75% over 3 years. So we need those to be rolled out and bedded down. So we're just at the start of a third phase, I'd say.
Thank you for that, and I really appreciate you breaking up into those three phases. And there's a few points I'd like to come back to later as relates to ITNs and innovation and the arsenal of tools. But with respect to kind of the taking stock of progress, and for those of you who are in the room, we're actually delighted at FP Analytics to launch an insight brief today on malaria prevention. And if you're online, you can access that on our website. But just to share what I think is a really important stat is if you look at the WHO's global technical strategy for malaria, to achieve those targets would increase Africa's GDP by an estimated $127 billion, boost international trade by almost $81 billion, and avert more than 600,000 deaths. And the reason I bring up those three stats is because it's as much about health as it is about prosperity and development. And yet we find ourselves, and it's a recurring theme today and throughout this week, of real challenges when it comes to financing and funding and just more generally political will and support for public health. And so, Phil, I'd love to turn to you next and bring you into the conversation. You're obviously with the Gates Foundation, an incredibly important institution and partner for governments, for private sector, for civil society. And ask you a little bit about what are the strategies at this particular moment that are necessary for scaling the level of funding available for malaria in light of population growth and trends relating to that, but also in terms of the need for innovation when it comes to financing, so that the progress that has been made and that Amar was talking us through is built upon rather than regressed.
Well, thanks so much for the opportunity to be here. We are at a really crucial moment. Just in 2023, we passed a major milestone. So in the 2024 World Malaria Report from World Health Organization, we passed the milestone of, in 2023, our malaria interventions collectively and all the work that's done by partners around the world, national malaria control programs, implementers, saved over 1 million lives that year. And it's been going up. So our malaria tools work, but they do require funding to get out. And I think right now we're seeing both donor pullback, we're seeing tremendous fiscal pressures in affected countries, and so many other concurrent challenges. I think one of the key things right now is understanding that a lot of the models where malaria was this kind of overly isolated off to the side need to update and adapt in response to kind of identified priorities and really listening to what affected countries are identifying as far as what their priorities are. Because malaria is incredibly connected to so many other things. We just had a great panel about primary health care. And primary health care is that front line for so many different health challenges. Now, in some parts of the world, say northern Nigeria, malaria is incredibly seasonal. And for 4 months, there's intensely high transmission. And if you go into a primary health care facility during those 4 months, malaria is going to be overrunning the whole system. And health workers, facilities, supply chains, everything is going to be stretched to the limit. And so if one is very focused on having, setting up and maintaining and operating a very strong and resilient primary healthcare system, finding some way to deal with the intense transmission of malaria is absolutely key. We look at the challenges of climate change, pandemic preparedness and response, agricultural productivity and economic development. And if you haven't read through the Insight brief, it is absolutely fantastic work, and congratulations on that. So rather than coming to this point and going to domestic financing donors and others, and as far as saying, here's why you need to care about malaria, which everyone should, really understanding how, from the starting point of what people are caring about, what priorities they're setting, and how malaria fits into that becomes really key. So then within that, I think we need to find ways of looking for new funding. There needs to be a way of placing malaria firmly within the domestic financing agenda. We have to keep building, though, the case for strengthened and reestablished donor funding, and also look at various different innovative financing mechanisms that can meet that. We also shouldn't overlook the consumer sector. I think as we see economic development continuing, there's a growing power in the from the consumer side in quite a few African countries, and looking and saying, what are the vector control tools that are desired from the consumer side, and where is there a willingness to pay, and how should we, on the innovation side and in terms of the product design side, really respond to consumer preferences and needs. And then all of that knitted together in the fact that how can we be looking for efficiencies, and how can we be looking for better ways of operating as programs to do even more with what tools and funding that we have. The dual AI, the dual active ingredient nets that Amar mentioned, remarkable progress in the early rollouts. And I think people aren't yet fully aware of how powerful the impact of those rollouts was. There was a direct health benefit when that was rolled out, and cases driven down, lives saved through the New Nets project. But not only was there tremendous cost effectiveness from the nets, health system costs went down. There were fewer cases, there were fewer hospital visits, healthcare facility visits, diagnostic tests being used, courses of treatment being done. So by actually switching to these newer nets that were actually more effective at killing mosquitoes and driving down levels of transmission, we saw health system cost savings. And so I think this just comes back to the point that has been raised throughout today and is just key. We can't be looking at each of these problems in isolation. That integration becomes really key to the pathway forward.
I appreciate so many of the points that you made, both in terms of the specific interventions that are proven effective and that need to be expanded further, but also this point, which again is a recurring theme about the need for integration and the breaking down of silos. And in many ways, it's a perfect segue to actually where I wanted to go with you, Professor Kaya. And you've had a really incredible career as a physician, in leadership positions with Ghana's health service. and really understanding the importance of not just the integration aspects that Phil was talking about, but also as relates to partnerships and the kinds of partnerships that are necessary to not just make the kind of change that Amar and Phil have been talking about, but sustaining. And so I'd love to bring you in, Professor, to talk a little bit about what are some of those lessons learned from Ghana as relates to the role of partnerships for sustaining funding and financing, for fostering local ownership, and ultimately strengthening health systems in a way that prioritizes malaria eradication.
Thank you so very much, and good afternoon, everybody. Let me put this down because I get a little bit excited when I have to talk about partnership, because the first thing is that we are all partners right now. It's one health, one globe. One globe, one health. Whatever happens in Ghana happens anywhere else, right? And we got to look at this from two main lines. One, sustainability. Two, ownership. If you partner with me and I don't have ownership of whatever we're doing, it's not going to be sustainable. So we in Ghana have come too far. We've seen so much, and yet there is a lot to do. We've been able to reduce about up to 97% of hospital deaths from malaria. But then you get to that 3%, and you still got to now even strengthen and find a way of getting down there to get to 100%. It becomes so hard. And then you also look at it and say, okay, Ghana is not an island. It has other partners, other borders, other countries. If we get it done and the next neighbor doesn't, you don't achieve nothing because it comes right back. But then when we look at the partnership, we categorize them in two forms. One is the local partnership, in-country partnership, and two has to do with the international partnerships. The local one, you got to look at the last mile. That child in the forgotten corner of the country, how do you get to that child? But that child is part of the community, so you got to partner with the community, the chiefs, the opinion leaders, the schools. It's intersectorial. You're never going to achieve it without looking at other conditions. Like you need to work with the Ministry of Work and Housing to make sure that there is enough good housing policies. Ministry of Water and Human Resources, you got to look at that so that they eliminate and make sure that there is provision of water. You got to look at the different ministries. And of course, Ministry of Finance, you talk to them, you let them know how much you save when we are able to undertake some of these interventions financially. Then you also have the clinicians at another part, where sometimes you undertake all the public health interventions, but at the end of the day, somebody will have malaria, somebody will be admitted, someone will need intensive care. So if you don't provide all those things that the clinicians will need in the hospital, we still record deaths, because when they have the complications, they die. Now, how do we do that? You bring public health and clinicians together, and then you try to talk to them about how to collectively take action on malaria. Then you move ahead, you look at the parliamentarians. They are very influential because this is a gentleman representing a constituency. So he's moving and he's talking about it as well. How do we get you to be stronger? We say healthy people, healthy economy, and you have a better country. So you talk to the parliamentarians, you talk to the rest of the sectors about this. But now, we all sit here and we say the future is for our children, right? So if you want a brighter future for your child, then you have to take the fight to the education side. So you have to go to the schools, you educate the people. You use all the modern tech. I mean, now the kids in our side of the world, they are catching up with all these technologies. So you need to find a way of developing health promotion and prevention strategies that the youth can easily associate with, and they can easily really want to see what is ongoing. So we go to the schools. Even if you do all this, you still need to have the international partnership, where you have to look into how you can be supported, especially in funding, in research, in areas of research is very, very important to be able to know exactly. Now, we have two types of researches. Sometimes you want to do a very complex and complicated research that might take 2, 3, 4 years to come out with the results. But you also have the operational research that you want results right away so that you can curve the situation. So we look a lot into research. Yes, excuse me a second, maybe. As I said, then we have to look into the private sector. Extremely important. What we tell the people is this: if your workers are healthy, you get more productivity. So don't think malaria is for somebody else. It includes you and your workers. As we sit here, we are all potential patients. And if we don't wipe off some of these diseases, and I come here and I say, oh, visit Ghana, you say, okay, if I'm coming to Ghana, I need malaria shot, I need yellow fever, I need this, I need this, I need this. If we eliminate malaria and I say, visit Ghana, the next morning you're in the airport, you catch a flight without having to go through all this. Isn't that a beautiful thing? So join us together, let's partner together, and we'll get malaria and we'll be all happy.
I love that, and I really appreciate your emphasis on a cross-cutting and intersectional, the need for both a cross-cutting and an intersectional approach. And if we take that framework and then bring it down to like, what are the actual specific techniques and tactics that are working, we know that next generation bed nets and especially insecticide-treated nets are a game changer. We've seen the results of that. And I'd love to maybe bring both Phil and Amar into this question, which is when you look at the future of those approaches, tell us a little bit about the need for expanding regional manufacturing and to exchange lessons learned from context to context, and how to ensure that the supplies that are needed are available readily and being used, and that there's uptake for that, and that those ITNs are part of a broader arsenal of tools, not a siloed or kind of just standalone intervention. So maybe Amar and then Phil.
Yeah, thank you. So no, a very interesting question. I mean, I think I think it's, I would put it in a broader context, which is we have obviously the constrained funding situation we have now. We have a lot of public capacity and publicly funded capacity, formally publicly funded capacity, now being cut and no longer being there. So it's not just funding, it's actually capacity too. And so the question is, how do we continue to innovate, in our case, in the case of vector control, insecticide-treated nets, whilst at the same time transitioning ownership and capacity across to the countries for whom this is the biggest concern, right? We know the donors are starting to step back. We know that recipient countries need to step up more. And so how do we, as the private sector, is something I think a lot about, how do we, on the one hand, continue to innovate, and on the other hand, do our part to partner with and build capacity in the countries that are affected by malaria and other diseases. So I think regional manufacturing is one of those. We know that all health is embedded within broader economic systems and many other systems, and how can we do both at the same time? So we don't just have this kind of old model where value addition is done outside of Africa and then the finished product is dropped inside. So we're working on that. We're looking at how we can build with the Nigerian government and a local partner in Nigeria a facility there and do tech transfer and actually create a new Nigerian company in Nigeria that can produce the next net. So we're well advanced on that. But there's also other things as well. So we've been talking in Ghana with the Ministry of Health, and we have a 14-year collaboration with the Noguchi Biomedical Institute, where we fund, I think it's about 22 African scientists in Ghana and another 5 or so elsewhere, on issues like vector control, the linkage with agriculture. So, malaria is unusual because, we're talking about an insect and resistance is connected to other things as well, on data science, on surveillance, on a bunch of other things. So helping to build this scientific capacity as well under the ownership of the Minister of Health, but, bringing our capabilities there. So they're just 2 examples. It's about manufacturing, it's about scientific capacity, and also many other things.
Fantastic, yeah.
No, I think we see the evidence for the impact the dual active ingredients, the new nets, can make. And in the fight against malaria, both in responding to this current moment and in pointing the way all the way forward to malaria eradication and the end of this scourge, having affected countries be really leading, not just engage in the implementation, but actively setting the agenda is absolutely essential. And I think one of the key things we hear is the real strong desire for local and regional manufacture. And I think there's a strong and credible case around the local and regional manufacture of bed nets. We just heard a great example around the pathway forward there. And I think that's one thing in terms of also making sure that we are responsive to needs and to priorities and the agenda that's being set. I think we also want to understand what's possible in terms of not just fighting one step at a time. Malaria, given numbers, time, and pressure, evolution is going to win. And we see constantly in terms of the last couple decades of the fight against malaria of introducing new drugs, new tools, and then seeing the continued evolution of resistance and that kind of seesaw battle. The only way to actually finish that is to eradicate malaria and end that for good. We can't with the current set of tools, but the innovation pipeline is tremendously well stocked. And by the end of this decade, we will actually have a tool set that is enough to actually finish the job and eradicate malaria. And you see, I think, the combination of innovation coupled with the strong leadership and the statements and declarations from African leaders, from leaders in Asia Pacific and the Americas. And I think there is this moment where the political will, the agenda being set by affected countries, and the innovation tool set can actually come together over the coming years to really enable something that hasn't been able to happen before. But it won't be easy, and it will require also kind of responding to this moment of crisis that we see and making sure that things don't go backwards while we continue to build for what's possible. I think there is real promise. You saw the announcements earlier this month that Gates Foundation is going to last for just 20 years longer, and over our whole time to date, we've dispersed about $100 billion, but we're planning over the remaining 20 years dispersing about $200 billion across all topics. And in the interviews, when asked about what is the legacy that he wants to see, Bill repeatedly kept coming back to malaria eradication, and all the cross-cutting benefits that would have. So I think this is a moment of being able to come together and kind of saying, how can we really respond to the agenda that's being set by countries, respond with innovation, respond with local manufacture, and so many other ways to have that intersectional coalition and multi-sectoral coalition to really finish the job.
Thank you for that. And, you were talking a little bit about the overarching goal here, which is the eradication of malaria. And just for everybody's awareness, as of 2025, only 45 countries in a territory are certified malaria-free. And if you look at our Insight Brief, whether in print or online, you'll see the map. And the overwhelming majority of those 45 countries, bar a couple, are in the global north. And so we have a very long way to go. And we are almost out of time. But I just want to give one last question to everybody, which is, at this particular moment here during the World Health Assembly, what is your number one call to action in terms of accelerating collective action as relates to malaria eradication, elimination, prevention? So maybe, Professor Kaya, I'll start with you and then go to Phil, and Amar, let you have the last word.
My call to action is very simple. Let's all come together to get malaria elimination back on track. What we have here, that's the call to action. And because this is the moment we have political will, we have community awareness, we have the NGOs, the CSOs, we have everybody into it, and we all have to look at one world, one health. Thank you.
Great.
I think we recognize that malaria is unforgiving. When things go wrong, including cutbacks in aid, or we saw with the flooding in Pakistan, we saw with cyclones in Mozambique, with civil conflict, or then with Ebola in West Africa. whenever something goes wrong, malaria surges in an unforgiving way, causing tremendous avertible cases and deaths, and those deaths being concentrated in the most vulnerable. This is one of those moments where things are going wrong, and unless we come together and come together quickly, there will be tremendous peril in terms of loss of life and tremendous setbacks. That jeopardy is juxtaposed with the tremendous opportunity that we have with the new tools, with the innovation, and with the strength of the partnerships that have been established. So this is a crucial moment to really come together to recognize the peril and to push forward to what is possible.
Yeah. Thanks, Phil. By the way, I should say 2 African countries have in the last year been declared malaria-free, Cape Verde and Egypt, so that's good news even with the current tools. I would say, I've been doing this kind of thing for about 15 years on the public-private side, and since the start, people have been talking about better collaboration with the private sector and blended finance and all this stuff, and frankly, the progress hasn't been that amazing. So I think now with public funding being massively cut, I'm hoping it might bring the right kind of shock to the system so that we can actually think a bit more creatively and practically about how to make these partnerships work at bigger scale and make them more effective. So that's my wish.
Thank you, Amar. Yes, indeed. It is both a wake-up call, but I appreciate each of your clarion calls as well. Thank you for being here, and thank you for participating in this conversation.
Next, please welcome Dr. Jarbas Barbosa da Silva, Jr., the director of the Pan American Health Organization, to discuss holistic health systems with moderator FP's Andrew Solinger.
Thank you so much for joining us, Dr. Barbosa. Good afternoon, everyone. Good afternoon, everyone. That was a fantastic conversation. We're going to have another one right now. We're so pleased to be joined by the director of the Pan American Health Organization, Dr. Barbosa. One of the things I wanted to kick off with is talking about the importance of primary health care. You've emphasized that as a critical key and a pathway to healthier communities. How is PAHO working with health systems to strengthen primary health care, to particularly address NCDs and mental health in the Americas?
Thank you, Andrew, for this very important question. I think that one very important lesson that you learn from the pandemic is that the renewed and strengthened primary health care is a backbone of a resilient health system. Mm-hmm. So we are working together, providing technical cooperation to our member states, working with allies, partners, in order to renew primary health care. You know that in some developing countries, primary health care until some years ago was very focused on the same framework that was established 45 years ago in Alma Ata. So it was more focused on maternal and child health and some communicable diseases. So it was this kind of primary health care is not able to answer the complex epidemiological scenario that we have nowadays in Latin America and the Caribbean and in most countries in the world. For instance, if we take non-communicable diseases that you mentioned, we estimate that only 25% of people with hypertension are at the same time aware that they have hypertension and have their hypertension controlled. If primary health care is not able to respond to this public health threat, public health priority, probably we still have the 34% preventable deaths related to non-communicable diseases that we estimate in Latin America and the Caribbean. So this is one example that how we need to move primary health care. We have established some strong alliances with the Inter-American Development Bank, with the World Bank. We launched in December 23. We now are working with 15 countries that are using loans that they have or they are planning to contract, not only to build the hospitals, but to provide better equipment for the health centers, renovation, training for the healthcare workers, connectivity, digital health, telehealth, telemedicine. So it's a comprehensive package. We have already 3 countries that have formally signed agreements, and we have another 12 that are in the backlog to sign formal agreements.
This is the PHC Alliance you're referring to?
Yes, this is the Primary Healthcare Alliance, and I think that this is one good example. Non-communicable diseases, also we have some advances in the region. We adapted the WHO HARTS initiative to the context of Latin America and the Caribbean. Some countries, as El Salvador, have already implemented the HARTS initiative in 100% of their health centers. So remember that I told you that in average, only 25% of people with hypertension have their hypertension controlled. In countries like El Salvador that implemented this strategy, the controlled proportion rises to 63%. So this is, I think, that already changing the game. And at the same time that is promoting and increasing the access at the community level, it is also provide a better organization, a better access to the secondary and tertiary level of the system. So I do believe that primary health care, this renewed and strengthened primary health care is the backbone for a resilient health system, is the best way to guarantee access, mainly to vulnerable population in our region.
Prevention. Let's, if we could, talk a little bit about mental health. PAHO established a mental health commission in 2023. This is on the back end of the COVID pandemic, which had tremendous impacts on mental health globally, not just regionally. And in 2024, the commission put forward its recommendations. Maybe you could tell us a little bit about that and how that integrates with the work that you do and how you're doing on those recommendations.
Yes, it is. I think that the pandemic also showed us how neglected mental health was, and somehow it is still neglected in many national health systems. Thinking about all the framework that many countries still have that is focused mental health care on hospitals, isolation of the patients with no ties with primary health care. So at this moment, my predecessor established a high-level committee that had a vice president of one country, but also have people with lived experience of mental health. And this high-level commission produced a very interesting report. I received the report, and this report was transformed in a resolution approved by our member states 2 years ago. This resolution, I think that there are some very concrete steps that are extremely relevant for the Americas. Unfortunately, we have, the Americas is the only region in the world that the suicide rate increased in the last 20 years, increased more than 17%. And this is only, of course, the tip of the iceberg. In many countries are young people that are committing suicide. So we are now supporting the countries to change their laws and regulations, moving from this old framework that they had focused on hospital and moving this to primary health care,
right,
to communities, to be more close to communities, to reduce stigma and discrimination, so people can feel more comfortable to come forward and to ask for support when they need to. I visited in some countries in Mexico City, for instance, in a very violent neighborhood in Mexico City, some very interesting initiatives under this new framework, working together not only the Ministry of Health, but also education, culture, social development, and with the community providing access for people that at the beginning could not have this kind of access that now are getting more access. Of course, we still need to universalize this kind of experience. We don't want to have only successful pilot projects in the country, but we really want to change the way that we are dealing with mental health in the region.
It sounds like a broader social effort as opposed to, focus on mental health issues, just really the background and the groundwork and the a social situation that a lot of folks are in. And that is a worrying stat to hear in the region. Thank you for sharing, but it creates a great concern. I Would love to talk a little about digital transformation, where we promised to talk about that today, and how important new innovations are in the work that you do. Maybe you could tell us specifically a little bit more about the Pan American Highway for Digital Health and how it's helping to transform healthcare. Telehealth, digitization, records, incredibly important in improving efficiency.
Yes, this is a recent partnership that we established with the Inter-American Development Bank, and we received some support from Japan, that's a member of the Inter-American Development Bank, based on 5 years of good collaboration with the Inter-American Development Bank to strengthen information system for health. We developed a tool to perform an assessment of the maturity of the information system for health, and based on this tool, the Inter-American Development Bank allowed the countries to prepare proposals to use the loans that they have to strengthen the quality of the information system. Using this partnership, countries in Latin America and the Caribbean mobilized more than $1.2 billion in the last 6 years. So based on this success, when 2 years ago, based on the experience that we had during the pandemic, because before the pandemic, digital health was already there, but I think that it had received a very low priority from countries. Now every country is trying to accelerate the process because they realize that this is one of the main important tools that we have to reduce barriers. At the same time, to guarantee digital literacy for health professionals, connectivity, health, telehealth, telemedicine is the best way to improve the quality of care at the primary health care and to reduce barriers, because one person that needs an appointment with a neurologist in the past needed to travel 1-2 days to have some economic loss because they work in the informal economy. Now they can have access to these specialists through telehealth, telemedicine. And in the Pan American Health Organization, we have 2 pooled procurement mechanisms. One for vaccines that is 42 years old. The other one is for medicines, medical devices, and other health technologies. And now we are offering to the countries through this pooled procurement mechanism comprehensive kits for telehealth, not only the device, but the software that is open source, training, technical guidance. So in some countries like Bolivia, Belize, Mexico, Guyana, and others, they are really taking advantage of this partnership with the Inter-American Development Bank, of these tools that we are offering to expedite the process. We really need to avoid to think that digital transformation is purchasing very expensive software.
Yeah.
Because we had countries in the region that purchased one software for electronic digitals in hospitals that cost $25 million, but it was not connected or linked to the electronic records that they use at the primary health care. So interoperability, a national framework aligned with the e-government initiatives, these are some things that we are supporting the countries because this is really a thing that are way forward to remove barriers and increase the access.
You've mentioned financing a few times now, and I'm just curious if there's a new approach to sustainable finance. One of the themes we've been hearing is that even with a lot of pressures on finance from some of the formerly big providers, regions and countries are finding innovative ways to work together. I'm just kind of curious if there's a different conversation that you're having now with the Ministry of Health and ministries of finance in the region about the importance of healthcare and how that's changed the conversation.
No, it's, I think, extremely important because I do believe that you need to break this lack of conversation that we have traditionally between Ministers of Health and Ministers of Finance. Ministers of Health saying, I need more money, and they are right, because the average of public expenditure in the Americas is around 4.5%, so we still need to increase 1.5 to go to the 6% that is recommended. And the ministers of finance say, no, you have funds, but you need to improve the efficiency. I think that both are right. So coming back to the start of our conversation, strengthen primary health care. And is one of the, I think, that most efficient way to use the limited resources that you have. Providing access to new strategies, new technologies that can eliminate malaria, like it was the panel before us, we had Belize that received the certificate of malaria. This year, Suriname, the first country in the Amazon basin that will be certified as eliminating malaria, advanced elimination of cervical cancer. Now we have the tools to eliminate the first cancer in the world. If we combine HPV vaccination with new molecular diagnosis, tools, and also treatment of the pre-cancer lesions at the primary health care. So I think that the best way to move forward this conversation is to provide some concrete examples that will change the life of the people, that will improve the lives of the people. So we are trying to work with the Ministry of Health to have this kind of projects that have the data, that have the evidence, to advocate with evidence, showing that every cent that they can get will change, will eliminate one disease, will reduce preventable deaths. So this is the way that I think that we need to move forward this conversation.
And I think that makes a lot of sense when you're talking with those Minister of Finance to talk about the economic return on human ROI. We were talking about that earlier as well. I don't want to leave us without covering regional collaboration. You've explained a lot of the interesting progress you've made within Pan-American progress, but what about outside of the region? We had, actually sitting in your chair an hour or two ago, Dr. Jean Kaseya of the Africa CDC. You recently entered into an agreement with the Africa CDC to work together. We were just listening to a discussion, the Ghanaian health minister talking about malaria and some of the work we were trying to do there. Could you tell us a little bit about the importance of regional cooperation and what you're doing with the Africa CDC?
No, this I think that is very important, Andrew, indeed. We signed an agreement with the Africa CDC, several topics, but one main topic, and it's very important for them and for other regions too, is how to establish a pool procurement mechanism. Because if we don't create a regional market, I don't believe that we will have a feasible regional production of vaccines, medicines, and health technologies. So if one country that has a producer needs to go country by country to receive the regulatory licensing, or country by country to negotiate the price of a vaccine, this will not be sustainable. So we are trying to export our experience. This revolving fund for vaccines now is supporting the development of regional collaboration. We signed in January with the government of Argentina, American producer Pfizer, and an Argentina producer, Synergium, the first tech transfer process on the PCV20, a conjugate pneumococcal vaccine, very innovative one. This will allow the countries of the region to have access to this vaccine by an affordable price, maybe the best price in the world, and at the same time we will strengthen the capacity in Argentina. So Jean Kaseya is very committed to learning how they can do a similar mechanism in Africa, so they will make the projects that they have there sustainable and feasible.
Wonderful. Well, you've shared a lot of great insights talking about regional transformation. We've talked a lot about how primary health care is a key element to health and working on NCDs. We talked about digitization and the importance of technology and some creative ways to push on financing and to work together and save money and do that more efficiently. Thank you so much, Dr. Jarbars Barbosa, the director of PAHO. Please join me in thanking Dr. Barbosa. Please.
Now, for a conversation about NCDs, please welcome Kana Enomoto, partner and the director of brain health at the McKinsey Health Institute, Dr. Mary-Ann Etiobet, the president and CEO of Vital Strategies, Dr. David Reddy, the director general of IFPMA, and moderator, FP's Allison Carlson.
Hello, everyone. Thank you for staying with us this afternoon, and I'm really excited. There's so much to build off of from that previous conversation, and we're focusing the next 30 minutes on NCDs. And as you all probably know, non-communicable diseases are the leading killer of people worldwide, yet they only receive about 3% of overseas development assistance. And often, the people most disproportionately affected are in low and middle income countries. So I'd like to start by sort of characterizing the situation and providing a little bit of a reality check for the moment that we're in. Marianne, I'd like to start with you. Often, NCDs are considered, unlike infectious diseases, a quote-unquote slow burn. And so can you characterize for us both the prevalence of NCDs globally and also why there's a real urgency to act?
Thank you so much for the question, and I'd actually like to start by emphasizing one of the things you mentioned, and that's about the impact on people. I think you call the title of this panel Policy to Practice, but I'd like to add Policy to Practice to People, because that's really what we're talking about here. Too long, the burden for NCDs has been placed on the shoulders of individuals, but we know that for the vast majority, these are caused by the social, the economic, and the commercial environments in which we all live. And so it's not really about personal behavior change, but more about cultural change. How do we create new norms and create new normals for all of us? I was just checking on my phone before I got up here to figure out when did we stop smoking sections in planes? 30 years ago. There may have been WHO meetings with people smoking at the tables. I weren't at any of them, but maybe there are some folks in the room, who remember those days. And so, I say that to share, we have come a long way, baby, but not long enough. And in terms of, how much more we have to do, I think part of the reason we're behind the curve is because the data has not been available. And so we know that the NCD burden is surpassed infectious disease burden in so many countries, including low and middle income countries, and now it's more than 50%, of deaths. And so we really need to catch up with the data as we are thinking about what to do with our scarce resources, in this context where there are so many shocks to global health and to global health financing.
Thank you for that. And this year, as you all know, is quite a big year for NCDs on the policy front. And a few years ago, or a few weeks ago, a few of us were in New York around the multi-stakeholder hearings on NCDs. And just last week, the zero draft of the declaration was issued, and we're on the road to the high-level meeting in September at the UN General Assembly. This will be the fourth high-level meeting on NCDs. And so, David, I'd like to turn to you for some perspective on what are the sticking points, what are some of the challenges, and what really needs to be prioritized now so that this high-level meeting in a few months will be different.
Okay. Well, thank you, and thank you for the invitation to be here today. So, I think there are enormous challenges, and we're all very cognizant of that right now, but there are also opportunities, and I think the UN General Assembly high-level meeting on NCDs is one of them. The case for investing in NCDs, and I stress the word investing, it could not be stronger. It's costing about $2 trillion a year right now, so it's an extraordinary amount of money. The other thing that I would just like to reflect on for a moment is the fact that we do have enormous competing priorities in terms of the funding that is required to address it. And that's just been intensified because I think we all predict that we will see slippage in some of the communicable diseases, which I really hope we don't see, but we need to be able to balance and manage both of these things together. NCDs are heading earlier. They're heading both the global north, where we see an aging population, the global south, across all economic strata. And so in terms of what we can do about this, the industry issued a call to action on NCDs, and we prioritized 4 things. The first is that we need continued innovation, so an ecosystem that favors innovation. The next is a commitment to invest, and that's to wisely invest, and also to ensure that we have synergies across the diseases and in everything we do. Then effective programs and policies, and finally accountability. Just a reflection on the word partnership. So in a world where there are scarce resources, we really do need to look to those around us who we can partner with and draw on the strengths of each individual group in terms of what their needs are and also what their abilities are and what they can contribute. I think there's been a lot of mistrust of the industry, and it's led to certain behaviors towards the industry where we're not really seen as partners. We've seen as providers of commodities, and yet we have hundreds of thousands of research and development experts, technical manufacturing experts that can lean into this. And I think there needs to be a real paradigm shift, and now is the right time to do this. To stop thinking about minimizing the influence of industry to maximizing the impact of industry as partners, because we realize that this issue and the current issues facing us are not going to be solved by any one group. We have to do this in partnership. And so if we can really, this is a pivotal moment, and it's a moment that we can really change the flavor and quality of our interaction, and I think start working a lot more strongly together.
Thank you for that. I'd like to pick up on partnerships and also something that you mentioned about different disease areas and effectively siloing of activity and how we can break those down. Con, I'd like to turn to you. You know, when you're thinking about action that has been taken to address NCDs to date, and you're coming from so much expertise and experience with mental health in particular, how are you seeing that challenge of all of these silos working toward a common, but also in some ways differentiated goal, and how those silos can be broken down for greater partnerships in action?
One of the ways to break down those silos is to get back to people, because people are not siloed, right? People with depression are more likely to have cardiovascular disease. They're also more likely to die from cardiovascular disease. People who have cancer are going to take longer to recover and have more likely to die if they also have an unmanaged mental illness. People with diabetes, I mean, it just goes on and on. These things travel together because people are complex. And for those who are bearing healthcare risk, like the ones who are paying for it, governments, insurers, employers, right? People with behavioral health conditions, they may be overall a small part of that book of business. They're 4%, 7% of the overall cost. Nationally, globally, it's 2% of overall health spending. But people with behavioral health conditions, mental health, substance use, they're driving between 40 to 60% of healthcare spending. So this is a vulnerable, complex population that if we don't address it in concert with NCDs, right, we continue to bear the cost as a society. And I think the other thing to do is that, you were saying 3% of global development funding is going to NCDs. We're probably not going to get to 90% or 50% just by having a health conversation, right? The health community's already made some decisions, and that's going to be incremental change over time. But I think the conversation has to be with the private sector, with finance ministers, not health ministers, right? It has to get outside of that because, we look at mortality, yes, 76% of deaths are NCDs. If you look at morbidity, right, mental and substance use disorders account for more years lived with disabilities than cancer, respiratory disease, cardiovascular disease, and diabetes combined, right? So if you're talking to employers and they're thinking about their pipelines, right, whether it is young people in the global south, whether it is aging populations in the global north, right, you have to, and then you're thinking about neurological conditions. As we think about the workforce of the future, people need their brain health, they need brain skills. We need to manage NCDs and we need to manage mental and substance use disorders to have thriving economies globally.
Thank you for that. And I'd like to turn to financing shortly, but before I do, Marianne, I'd like to turn back to you. Can you provide some concrete examples of some of these innovative partnerships that you're experiencing in practice? What can be looked to and pointed to that we could all learn from?
And thank you for the question. And before I answer that, I just want to make sure that we are being very specific and discerning when we talk about private sector, the contributions of the private sector, and the types of actors in the private sector and different sectors within the private sector, because not all of these things are equal. There are good actors and there are bad actors. And so I think when we have these conversations, as David mentioned, there are definitely contributions that many entities across private sector can use to bring to the table. And I think part of what we need to do, you asked the question about solutions, is actually get in a room and devise the solutions together. But at that table must be government and must be patients, people with lived experiences. And I think if we do that, if we make the process inclusive, if we make the process participatory, if the process is driven by data, if the process is based on evidence, if we do all of that, as well as hold ourselves accountable from data, then we'll actually find the solution that works for that individual that is coming to healthcare with multiple needs, both at one time and across time. There are many examples, in terms of success. I can think of some around the financing. We're living in a area right now, a time right now where there's huge constraints on financing. We need to bring in capital from wherever we can get it, whether it's private sector and looking at blended financing instruments, but also thinking about domestic resource mobilization, because at the end of the day, we need to support countries, in their work towards having healthcare sovereignty and being able to mobilize the resources. And I'll just end by saying we have a solution for that. That's health taxes. If we increase the price of tobacco, sugary beverages, and alcohol just by 50%, we save 50 million lives in 50 years. That's something that we can do day one. It's also something that will generate health savings, health benefits, as well as I mentioned the revenue, within a year or two. So we don't have to wait. There are things that we can do right now. And that government revenue is going to be used to purchase healthcare services, which can be provided by a multiplicity of actors, including local private providers.
Thank you, and I appreciate stepping back for a moment and talking about the need for greater candor, greater discussion, and if it's in closed-door settings, but bringing everyone around the table to talk about what are the real challenges and forge partnerships in earnest, to David's point, to garner trust, and that will happen and needs to happen over time. But also the point about needing to finance and identify ways to finance interventions, and domestic resource mobilization is definitely an important one. And I think the Zero Draft was stating that it's calling for 80% of member states to institute excise taxes on things like tobacco, alcohol, sugary beverages, which are a challenge in terms of implementation in their own right and definitely need complementary sources of funding. And so when you think about concrete pathways for financing and the sort of quote-unquote best bets that will generate returns on investment, understanding the fiscal space is tight, and we were talking about that earlier. David, I'll turn to you. What are your thoughts regarding some of the best bets and innovative ways to, with limited resource, drive real impact on the ground?
I think the starting point is that a lot of really good thinking's already gone into this. And so the WHO, the Lancet NCD Countdown, and the UN Interagency Task Force on NCDs have identified the best bets. I thought what was really interesting within the Lancet one was they talk about best buys, but they also talk about quick buys, because they identified 49 best buys, if you like, but 25 of those are quick buys that could actually begin delivering a return on investment within 5 years. So there really is a strong economic case, and there's already a pathway laid out towards this. I think one of the key elements is moving from effectively a reactive position on NCDs to a preventive position. And so this requires a real awareness, and you mentioned the different factors, both societal, environmental, et cetera, that lead into this. And I also take your point about a lot of this is put on the shoulders of individuals. If you read the book Exercised by Lieberman, it's many of the things that are referred to as lifestyle choices are just part of our inherent biology, which are difficult to overcome. And then also I think that, looking at the role of vaccines in this is also critically important. I'd point out two examples here. Human papillomavirus, reducing cervical cancer, HPV vaccine, reducing liver cancer. Combined, these could save or prevent an additional 1 million cancers a year. The return on that would be enormous. And then you've got the communicable diseases, the viral illnesses. Influenza vaccination can reduce, in people with severe cardiac risk factors, can reduce heart attacks by 2/3. But if any of you have ever watched the movie Awakenings, about that catatonic encephalitis, that was actually, it coincided with influenza infections, which probably contributed to it, and actually had people moribund for decades. And so vaccination can also help prevent this type of thing. And I think ultimately, one of the big enablers is just going to be taking a people-centric approach to this, because so much of the comorbidities are overlapping, and so we can achieve far greater synergy within our best buys.
And that echoes so much of what has been said this morning about integration in terms of approach and strategies and how to think about that a little bit differently. On financing and funding, Kana, I'd like to pick up with you. I know you're working with the Coalition of Mental Health Investment, and I'm curious about that work that you're doing and what you're hearing from funders in this space and how they're thinking about priorities and also returns, both in terms of investment, but also returns to health.
I would say, you know, in the high-income countries, so just in the United States, right, behavioral health is a $256 billion market. And from 2020 to 2022, you saw 4x private equity money going into mental health. And mental health, within digital health, mental health is the leading disease indication for investment. So there is clearly, I mean, we have, you know, over 10 mental health and substance use unicorns. So there is definitely a case to be made in terms of, you know, return-seeking investments. That's possible. But it's also, you know, for a broader range of geographies, just the straight return on investment in human lives and in human cost. And so we have done a partnership with CHAI, looking at if we could scale access to mental health services, to prevention, treatment, early intervention, recovery supports, to 90% of people who needed them. So we took kind of a 90-90-90 framework. We borrowed a page from the Fast Track goals. And we said if we could screen 90% of people, if 90% of people who screen positive had access to an evidence-based treatment, whether that's a therapeutic or a psychosocial intervention, and then 90% of those people could actually make progress toward their recovery goals, what would that impact be? And what would the ROI be? Yes, clap. We should clap for that. We should do this. We need to be committed to this. We could save $4.4 trillion by 2050. Right? There is a huge return for us as a society. We have the science. We have the technologies to do these things already. And then there's innovation coming, you know, as we speak that's going to even accelerate that further. But we're not doing it yet. But you know, for every dollar invested, you could get $5 to $6 back in return. And you know, the argument, in addition to that $5 or $6 you get back, as you said before, there is a person on the other side of that. There is a family on the other side of that. Right? And there are children on the multiple generations on the other side of that. So this benefits not only on the financial end, but on the human end in our communities and our countries.
What actions can be taken now to catalyze that? If you were to, again, have the call to action that we've been talking about today, understanding there are a number of innovations. We talk about tech-enabled medicine, and we just heard about the Pan American Innovation Highway. You know, how can we think about this differently, and how can the actions be integrated and accelerated to both bring down cost and increase access? Marianne, I'd like to turn to you.
I'd like to focus on, you know, what we've already discussed around, you know, the missing person on the panel, you know, the person with lived experiences, although I know all of us are probably living, you know, with NCDs as we speak. It's that pervasive. I think we forget that the public is living their lives. You know, they're not engaging with us on these conversations around global health. So we actually need to reach out and have effective dialogue with the public about these issues. I don't know the data, but I think if you probably surveyed, you know, kind of a cross-sectional, diverse, cross-sectional body, not a lot of folks would know about mental illness, know how to get diagnosed, know that there are treatments available. If you mention diabetes, they may not actually know what that means. And so I think we need to do more, you know, to engage with the public and have effective dialogue with the public, because that's where the demand starts. You know, that's not just demand for good policies and government services, but also demand for innovation.
Thank you for that. And David, how would you like to pick up on that when you're thinking about catalyzing action? I know in the report that IFPMA recently put out, you are articulating those 4 categories. Where can we lean in for near-term impact?
So just a couple of thoughts. One is on early interventions, because if you can intervene early, so if you have appropriate screening, early intervention, you save the real escalation in healthcare costs that occur later with hospitalization, et cetera. And I know it's maybe a bitter pill to swallow initially, but in the long run, it is going to be far more beneficial to our economies, to society, and to people. I think the other thing is to have and I fully agree with you, a really good quality of dialogue. And I mentioned, I'm going to be provocative now, and I mentioned mistrust of the industry. Actually, huge swathes of society don't trust you either. They don't trust the credentialed elite. And so how can we actually have a really different quality of dialogue with one another and with the wider public? Because what they bring in often is beliefs. It's not founded on science, and we chastise them for that. But actually, every one of us has beliefs. So we all have our own belief systems, and I think we have to start off from a perspective of having a different quality of engagement where we listen to one another and find out what one another's needs are, and then either contribute to resolving the problem or working together on issues. But it all starts with a different quality of interaction.
Thank you, very well put. And Kana, from your perspective, how can we foster that dialogue? And how can we really reach out to those communities who don't have the opportunity to be in this room and communicate and connect more effectively?
Well, I very much agree with what Marianne has referenced, which is engaging with people with lived experience, right? Going to people where they are to ask them what are the solutions that they'd like to see, and empower them to drive some of these conversations. And I think also bringing in both public and private sector folks who are bearing risk for the health of our communities. I think one of the actions that I'd love to see people take is kind of breaking out of the silos of like, I see like if you have a hammer, every problem is a nail. You know, if you're a grant maker, every health condition needs grants. And then somehow people think that making money is kind of a dirty word, and we don't want to have those kinds of arrangements. But if we want these services to scale, someone has to be able to make money, right? Like it's not, we're seeing the public funding dollars going away, diminishing. We have to make the economic argument, and we have to have the public sector, the private sector, and the communities coming together to find a solution.
Thank you. And I think it is important to be provocative and to challenge ourselves and each other about what can and needs to be done differently. And so in the minute that we have left, from each of your perspective, at the end of this week, with respect to really advancing meaningfully the fight to combat NCDs, what would be a concrete win for you? David, I'll start with you first.
I'd say put the ideologies aside and put the problem at the center of the table and say, how can we each contribute to addressing it?
Thank you. Marianne?
We got to figure out how to pay for this. Taxes, taxes, taxes.
Mental health and substance use are universal problems, and they deserve universal solutions. I think every time you're talking about any kind of approach to managing disease and promoting health, that mental health and substance use are right there on par, and that the expectation should be that everybody has access.
Thank you for those calls to action and for challenging all of us here to do more and to do it together. Appreciate you being here.
please welcome Dr. Jennifer Barsky, founder and executive director of Meno Global, Dr. Pauline Mackey, the director of UIC's Center for Health, Awareness, and Research on Menopause, Dr. Klaus Runge, Senior Vice President, the Global Head of Public Affairs, Sustainability, and Internal Engagement, and the Chief Health Equity Officer for Bayer, and moderator Dr. Maisha Alam for a conversation about why menopause matters.
Hi, everybody. Thank you for sticking with us. I am incredibly excited to have this conversation on Menopause Matters with this group of panelists who are really the trailblazers and pioneers when it comes to an issue that is all too often overlooked on the global health agenda, on the global finance agenda, and even on gender equality issues around the world. And we at FP Analytics have been incredibly fortunate to partner with Bayer to lift the veil on menopause and to really shine a spotlight through rigorous research. And so today we're launching a new report on the health and economic impact of menopause. It's an in-depth study comprised of a global landscape analysis and detailed case studies on the US, Canada, Germany, and the United Kingdom. And I encourage everybody in the room as well as online to use the QR code or the links on your screens to take a look at that report. And many of the themes we touch on in the research we'll have an opportunity to speak about today. So thank you again to all of you for joining us for this conversation, contributing to the research, and being committed to this issue. I'd love to start with a simple fact, which is that women's experiences of menopause are shaped by a range of socioeconomic determinants, varying from one person to another, from one context to another. And yet, one aspect of menopause, which is virtually universal, is that it remains largely invisibilized, both in terms of what that means for a person experiencing it, but also when it comes to healthcare policies, budgets, treatment options, and just public discourse. And so let me ask you, Klaus, I'd love to start with you and then Jennifer bring you into the conversation on this, which is how can we, and by we I mean policymakers, employers, the media, civil society, how can we collectively better humanize women's experiences of menopause and raise awareness to both demystify and destigmatize what is a universal experience?
Well, thank you for the question. As a male panelist, I feel I have to earn my seat first. So I'm 50 years of age. My wife is in kind of the same age span as I am. I won't disclose details. But she's going through menopause for roughly 2 years now. And I can tell you it's very burdensome on the individual levels. So her night awakenings are mine. Her depressions are ours. And it's really something that can really weigh heavy on her day-to-day work, on her day-to-day life. Yeah? So that's something I wanted to start with. On a professional side, I've worked on menopause topics already like 20 years ago when I looked into the socioeconomics of menopause. And before we go into details of these, I can tell you so little has happened since then. We see little progress here and there in terms of research, but there is so much stigma around this period in a woman's life, which is not a disease, it's a transition, that I think we all should figure out how to do things better in the next 2 decades to come. We have 1 billion women worldwide who have gone through menopause and who are now post-menopause. And we know little effects about the long-term implications of what happens physiologically to the female body in that time. So I think it's a call to action that we all need to spell out. If you look into the workforce, the age group of women affected by menopause symptoms is rapidly growing. So roughly 10% of the workforce in industry nations is actually in that period of life. They have severe issues on delivering their day-to-day tasks when they experience symptoms. We talked to them in the pre-discussion. So also economically, it would be wise for countries to partner up with the private sector, but also with physicians who often know way too little about the disease, or not the disease, sorry, about the constitution, the transition, that it's really time to change the situation for women in need.
Yeah, there's a lot I want to unpack that you mentioned, but Jennifer, let me bring you in at this point, because I know at Menno Global, you are very much dedicated to this issue of destigmatizing, demystifying, and helping people understand what the reality is of menopause.
Thank you very much. I mean, I think that we should actually pause here for a moment. I could come out with tremendous amount of data, or I could give you a single data point, which is, I believe this is the first ever menopause panel at the World Health Assembly. So I think that's pretty amazing. But it's also unfortunately very telling, as Klaus was saying, you know, we have not seen action on this issue. This is an issue that has been around forever, since the dawn of time, most likely. I'm sure Pauline could perhaps correct me on the clinical front on that. But it has been virtually invisible on the global stage, in economies, in communities, and even among friends. I was early menopausal at 40. It happened to me when my mother was dying of breast cancer. She died a horrible death. And I started sweating, and I had no idea what was happening to me. And I went to the doctor, and the doctor said, "You have menopause. Go on the pill for the next 10 years until you should have had menopause." But I was terrified of breast cancer. And I also didn't feel comfortable discussing it. And my symptoms were brutal for many, many, many years. And so we now have to think about my situation and multiply it by thousands, millions of women. And some will breeze through. Some will have menopause and they will be empowered because they are no longer perhaps reproducing. Maybe they get to go to the mosque or the church or whatever the case may be for the first time for a wedding because they're not menstruating anymore. So for some women, it is liberating, it is empowering. For other women, it can be debilitating. And they are often misinformed, underinformed. They are perhaps living in silence. They may not even be discussing it with friends or family. It's truly something that only arises for you when it slaps you in the face, when it happens to you. And I've spoken to hundreds, perhaps even thousands of women across the globe who are experiencing the same thing. So the starting point for us is this lifting the veil. And every time we have a conversation, we are doing that. And so I think we are shifting the dialogue very slowly, but we are on that momentous journey now.
I appreciate both of you setting the scene with both, with such personal perspectives, but also very pragmatically. And I'd love to shift the conversation, having, addressed that question to what can we do about it? And Pauline, I'd love to bring you into the discussion. And, you are at the helm of both clinical work, but also research and advocacy and networking and really moving the needle in many ways. And so help us understand, how can menopause be better integrated into both primary health and specialized care? And how can medical training be improved to better equip frontline health workers to support menopausal and postmenopausal women?
Thank you, and thanks for the question, and how wonderful to be here at FP talking about menopause. I thought the height of it was Davos last year, and it just keeps going and going, which is a long way from the time I was in the back halls studying menopause at the NIH. So it's really important to make the case for care. So you have to motivate health systems to care. And here's where the data from McKinsey and the World Economic Forum comes in. They quantified that the annual GDP loss to menopause is $120 billion a year. Now, that's a lot of money to be recouped. So then the question is, what are the solutions? How do we get that care into primary care. So at the International Menopause Society, we have a solution. We have 15,000 people from 127 different countries who are registered for our IMPART training. This is a virtual training that's available across the globe. We need to scale those solutions. And as Dr. Kumar from the WHO mentioned earlier, there's a science to training. There are better ways of imparting menopause training, new tools of the science of how we learn and how we need to relearn, because we forget after we learn. So that's critically important. Another theme that emerged from earlier today is oftentimes the solutions have to be self-guided. I need to be able to diagnose myself with the proper evidence-based tools and then have those tools available to help me. It's really important to reach people not only in higher income countries, but also lower and middle income countries, which might seem like a high burden, but there are evidence-based approaches to delivering care through your cell phone. There are behavioral interventions that help with sleep, that help with hot flashes, that help with mood. And then you have to make the case for why you want to provide care for the woman. So we heard from Jennifer and from Klaus these personal stories. But I think we also need to demystify, building on how Salinger started out today. How do we myth bust about menopause? Is it benign? How many years do you think women experience hot flashes? Any guesses? 7.4 years on average. How about if you're black? 10 years on average. That means 50% of black women experience hot flashes for more than 10 years. In our research studies, when we put hot flash monitors on women and measure them objectively, black women in the south side of Chicago had on average, any guesses? How many hot flashes per day? 27. How often do we wake up at night when we have a hot flash? 75% of the time. So let's put all of that together. Night after night, week after week, month after month, year after year, these women have hot flashes that aren't being treated. So is it surprising that the economic argument is $120 billion per year, especially in light of how women comprise the workforce? So a lot of it's education, dissemination of better evidence-based treatments, and training our providers in a way that recognizes how busy they are and how we learn.
Thank you for that. I mean, those statistics are incredibly illustrative of the scope of the problem. And with respect to the economic impact, you know, our research specifically into the US, Canada, UK, and Germany shows similar trends in terms of the costs of inaction, but also the multifold returns on investment, both quantifiable and not. And I think one of the things that's really important to recognize is virtually everywhere in the world now, there's an understanding that for economies to grow, women have to be part of the workforce and to be able to fully participate. Well, you can't achieve that goal unless and until you're supporting menopausal women in the workplace to be productive and to do the best they can. And so it's not just about the healthcare sector getting, you know, to the table and waking up, but it's really about ministries of finance, private sector employers, and so forth. I want to talk a little bit about the specific approaches to care and treatments when it comes to menopause. And, you know, Klaus, I'd love to come back to you and ask you a little bit about what are some of the innovative approaches that have shown promise in terms of improving women's quality of life, and how can treatment options enable personal choice so that it's not mandated by any one public health provider or insurer, and so that women can be making informed choices about how they receive the care that they need?
Yeah, thank you. Before I come to answering that question, I would just like to add a few thoughts and again, a personal example on how also encounters with OBGYNs sometimes happen. I remember being at a large sexual and reproductive health congress in Thailand a couple of years ago. And I met, I won't disclose the name nor the country, but I met the head of the medical association, OBGYN medical association of that respective country in Southeast Asia. And I said, look, we are working on some menopause solutions. We have a new asset in our pipeline that we're developing. And he said, like, we don't need it. Yeah? So When our women get a hot flash, they just take a cold shower. They love it. They love the cold shower. Everything's fine. And I think that's something to start with. I mean, if you have all the burden that's just been described, and you meet a professional seeking for help, and then the obvious reaction is ignorance at its best. I think that's something to really tackle. So we need to get into the curricula of those people being exposed to women and to train them and to make them receptive to the topic. So secondly, the second part I would just like to refer to is I did some willingness to pay research 20 years ago on menopause solutions. And what you see is that the women have a pretty high willingness to pay for solutions, which is reflective of the individual burden of disease. But if you then talk to healthcare decision makers, the willingness to pay really drops. And the difference between the individual and the healthcare system is probably one of the biggest across other different interventions in the healthcare system. That's also telling. So it's not just the individual physician, oftentimes, not all the time, oftentimes, it's also the system that has little respect, I would say, to include this in services that need to be rendered to women. Now, the final part is, and that's where the industry comes in. I work for a pharmaceutical company that has decades of experience in women's health, mostly contraception. But of course, we have now been able to develop a new product, which hopefully will be available to women worldwide soon. There's another manufacturer with a similar approach that perhaps some women in need, especially those who don't have an indication for hormone therapy, hormone replacement therapy, have a new option at hand. So, and that's something where we engage physicians on, and that may also help tell the story, spread the news, but also help people rethink how they treat women in this period of their lives.
Thank you for that. And it's in many ways, we've talked about the raising awareness, we've talked about the treatment options, but when it comes to making change and lasting change, what's also really important is policy and research, which are two of my favorite topics. And I'd love to bring all of you, all three of you, into the discussion on this. You know, it's really interesting when you look at national health strategies for countries that have a national health strategy, which is obviously not all, and plenty of countries where health strategies that are at a provincial or state or some other level, very, very, very few mention menopause at all. And similarly, if you look at economic growth strategies and so forth, very few mention menopause at all. So there's really something missing when it comes to the policy piece. And the other kind of side of that coin is the research, the evidence, the data, something that both of you, all three of you actually touched on. And so I'd love to ask you, from your vantage points, what are the most critical research gaps that need to be filled at this stage in order to change the tide on menopause? And what are the most important policy actions that need to be taken? So maybe Jennifer, we'll start with you, Pauline, and then Klaus.
Sure, thank you. I mean, my focus very much on low and middle income countries. And I think what was shocking to me to learn is that our global surveys and many of our national surveys on demographic health only go up to age 49. And then perhaps we have aging surveys in some countries, but what that means is we have no continuous data. And not only do we have no continuous data, but we often are asking only a single binary question. Have you menstruated in the last 6 months? So it's very difficult to imagine how are policymakers supposed to be making policy in the dark? Because I think of menopause as a black box full of compartments. We talked a little bit about social determinants, but social determinants matter enormously. Economics, culture, religion, family, all of these things don't just qualitatively influence a woman's experience. We know from small studies that they actually influence levels of symptoms. Stress impacts age of onset. But currently, what we don't count doesn't count. And what we don't count is we don't have a picture of women's health from the age of onset. We don't have a picture of their symptoms. We have no dedicated modules for menopause. And even when we do discuss it, the women don't have the terminology to even know. So if women don't know what is happening to their bodies, they're not going to be able to report symptoms. And what's critically important about that is there also is no care-seeking behavior. So I think what's important to recognize, and I can talk a little bit more about policy, but I think the way we see it at Menno Global is every woman, as a baseline, deserves to know what is happening to her body, and then have the right to decide what to do about it. And the rights come from policy. But right now, we have no demand-seeking behavior. There is no demand in many countries because they don't know what is happening to them or they don't know what is coming. And they can't associate their symptoms with the potential long-term health span and longevity issues that could follow.
Thank you.
Thank you.
So we in the United States have been working at a policy level, both on the Hill and on a state-by-state basis. The active ingredients on that are awareness, care, and research. Among the most important research questions from my perspective are the economic ones. How do you show a return on investment? How do you demonstrate efficacy of workplace policies, of national policies? What's the science for that implementation research? Because there are some sectors that are invested in menopause. Most are not. So the economic argument has to be paramount because they're not going to do it for the goodness of women. They're going to do it for the economics. So we need to build these partnerships and explore what are the best ways of delivering care in lower, middle, and higher income countries so that we can help people to get those returns on investment that the data that we're hearing about suggest.
Yeah, I think if you look at the numbers, 20% of OB/GYNs are well trained on treating menopause, and only 20% of all women feel actually well informed about what's going on to their body. So the question is, how do we get these 20% up to, I don't know, 80 or 90% within a reasonable time frame? So I think that's the ask. I think what it requires is international collaboration. We have a higher proportion of women in industry nations suffering from menopause, but in absolute numbers, of course, LMICs are outnumbering by far. And we have to leverage cross-sectoral partnerships, something which went pretty well around the pandemic, to have the private sector, governments, other institutions collaborating on finding solutions. And then, of course, I think it's key to train physicians and caregivers. That's a must. I think that's probably also the first call to action when you talk to policymakers. And we also should highlight that there's some frontrunners. So the UK and Canada at least have brought forward some measures to improve the situation for women, especially working women. And that should be a good example for others to follow suit, adapted to the local systems, requirements, and that's what we will call for as a company. And finally, it's inclusion of technologies into the healthcare system, be they new, be they existent. The guiding principle always should be they should be evidence-based, because a lot of women experiment with stuff that is not experiment-based because no one knows.
Yeah. As I'm listening to you all speak, and especially just now, a couple of things stand out. One is that, and I think, Jennifer, it was you who mentioned this, when we think about aging policy, you know, at the global level, the landmark frameworks on aging, whether that's MIPA, the Madrid International Policy on Aging, or you know, others, menopause is completely invisible from them. And yet, of course, it's inseparable from the question of aging, right? Similarly, when it comes to things like ICPD and policies around family planning and reproductive health care, as you said, surveys and any kind of attention goes up until the age of, reproductive productivity, and then it's as if reproductive health no longer exists for women who are older than 49 years old. And so, and this is all happening at a time when people are living longer than ever before across the globe in high, middle, and low-income countries, and where, especially in the Global South, there is a focus on the youth population, but a complete negligence when it comes to older populations. And so we're just about out of time, but I have just one last question that I wanted to ask all of you, and please keep your responses brief, if you will, which is, what needs to change for a life course approach to be taken when it comes to menopause? Because that really seems to be what's missing in many ways. And Pauline, you're nodding your head, so maybe I'll let you take that one.
Menopause care is primary care. Menopause care is primary care because all women go through it. So it needs to be integrated into medical care through expectations that it affects half the population, and there are estrogen receptors in every bodily system, from your eyes to your lungs to your liver to your bones, and it's preventative care. What we do for ourselves at midlife is an opportunity to optimize our health for the rest of our life. So I think that lifespan perspective and the idea that it should be natural because it's part of the aging process is a really important one.
Yeah. Thank you for that. I know we're out of time, but I felt that was a really important question to ask. And for our part at FP Analytics, it's also how we're approaching our research agenda. And so actually, as I mentioned, we have a new report out today on the impacts of menopause. And just a few weeks ago, last month, we launched a report on family planning for a prosperous future, and again, taking that health and economic lens, and in partnership with Bayer. So thank you to all of you for participating in this conversation, supporting the research, and really bringing this topic to the forefront of the agenda when it's been off the agenda for so long. Thank you.
Thank you.
Finally, please welcome Jose Luis Castro, the Director General and Special Envoy for Chronic Respiratory Diseases at the World Health Organization, for a conversation with FP's Andrew Solinger about the next chapter in global health.
Jose Luis Castro, thank you for joining us. We're standing between everyone and lunch, so we better be very interesting here. And we're going to be very interesting. We're talking about an incredibly important topic, chronic respiratory diseases. And Jose Luis is the Director and Special Envoy for Chronic Respiratory Diseases at the WHO. What does the Special Envoy for chronic respiratory diseases do at the WHO? What's your role?
Thank you, Andrew, first of all, for having me here, and also to be able to highlight chronic respiratory diseases in this forum. This positioning is one question that I get asked often. Reflects the commitment of the WHO and the Director General to highlight chronic respiratory diseases, especially asthma and COPD, chronic obstructive pulmonary disease, two of the leading causes of mortality in the world that often, get sidelined and ignored and not included in policy discussion. So the role of this position is to elevate this issue and policy discussions in the political agendas, and also to bring awareness and resources to address this issue.
Thank you for explaining. And you have described CRDs as the invisible epidemic. Why do you think they've been so neglected and not on the agenda? And despite the fact that they're a massive burden in addition to a horrible health condition.
Chronic respiratory diseases, and especially those two diseases, asthma and COPD, affect over 640 million people in the world and cause 4 million deaths every year. And yet, for example, in 2024, just before I assumed this position, it was only mentioned in the news by a major newspaper once, and it was reporting on the death of the Irish singer Sinead O'Connor. Now, 4 million people died that year in 2024 of this disease. They don't make headlines. They are silent, and because they are invisible and they're not infectious, they're often not seen with a sense of urgency that requires a mobilization of resources or the press to speak about them.
Got it. Maybe you could tell us a little bit about access. You meant, a tremendous number of people, 640 million, I believe you just mentioned. Many people with asthma or COPD can't get a basic inhaler. And what needs to change, and who's responsible for making that happen?
One of the challenges with these diseases is that it's difficult to diagnose asthma, for example. Although there are treatments available, they are difficult to diagnose. And also, then the cost is a barrier to access those medicines. Also, the medications are not, the inhalers are not widely available in every country. That is why the global health community is asking for, as part of the political declaration, the access to inhalers for bronchodilators and corticosteroids as for the treatment of asthma and COPD, to be part of the political commitments that are made so that they are affordable and that they are accessible to all those who are suffering. But I think the diagnostic piece is a key issue that needs to be addressed as well. Mm-hmm.
We've been talking a lot about finance today, obviously, considering the current state of affairs. Maybe you could just give us a minute, an understanding, the need to create that understanding and political will. What are the financing mechanisms available, or what would you like to see available for CRD?
For sure. When we look at what are some of the driving causes of these diseases, there are two that are primarily responsible for example, COPD, and that is tobacco smoking and air pollution. And these two issues, we have effective policy solutions to address them. The implementation of the WHO's recommended Empower strategy is one of those methods, and that includes taxation as one of the ways that governments can raise revenue in a sustainable way to address these public health issues. Also, reducing emissions and taxes on emissions is another way that funds can be raised. But when we address these diseases, there will be a substantial reduction in the costs of healthcare to the countries and to the economies. Right now, there are millions of people that are sick and that require treatment for life, and that is a substantial burden. If we are able to prevent that, and we are able to reduce the burden on the countries, the economic burden on the countries.
I don't know if you were around for the panel before the last, where Akana Anemoto of McKinsey Health Institute, that was her recommendation for how to close the financing gap. Tax, tax, tax. It sounds like you would come up with a similar kind of a scenario. Are there countries or leaders that you think are approaching and tackling this issue, both on the financing side and just recognizing CRDs effectively, that you would share with us to look towards?
I think that there are countries that have taken significant steps to address this issue. We were encouraged. China, for example, in September elevated COPD as one of the top 3 priorities in national public health services. This is a disease that affects over 100 million people in that country, so it's a significant step to recognize that. Other countries like South Africa have taken steps to address chronic respiratory diseases. But the key is that while many countries also put this into their national plans, only a fraction of them are implementing and putting resources to make it happen. And that's what we need to, that's the gap that we need to bridge, is the effective implementation of these policies, and then ensuring that the all the key players in the countries are able to deliver and address the diseases.
You raise an interesting point. We're going into the fourth high-level meeting on NCDs, and the last was seen as something of a policy success, but an implementation failure. How do we increase accountability on this front? What does real accountability look like in global health, and how do we get beyond declarations and move to delivery?
That's a very good point. I mean, there's been this will be the fourth high-level meeting on NCDs. And clearly, what is important is to ensure that those commitments that are made during these meetings translate into action, effective action in the countries. To ensure that that happens, there have to be indicators that we all agree that set targets and allowed for accountability to be taken by different sectors, by Parliament, by the civil society, by the press, by all those that hold governments accountable for delivering on their commitments. So it is very important to have effective measuring tools and reporting tools, as well as ambitious goals to achieve that.
Are there any partnerships across regions or across sectors, since you're mentioning these cross sectors in particular, that you would like to see develop?
Definitely. I think partnerships like groups of parliamentarians that are coming together, for example, like the parliamentarians for the Caucus of Parliamentarians for Tuberculosis, which has been in existence for 10 years. It's an effective mechanism that ensures that money is put in the national budgets to address this issue. Similar efforts to address non-communicable diseases, and especially chronic respiratory diseases, will be important. The Global Alliance Against Respiratory Diseases is a group that WHO convenes of the leading scientific organizations in the world addressing this issue. And this group has come together with 5 priorities, 5 asks for the political declaration to address the crisis of chronic respiratory diseases. That among them is ensuring that chronic respiratory diseases are part of the political discussions, part of the development agenda, that the access to affordable inhalers, corticosteroids, as well as bronchodilators is assured, or a combination of those, as well as investments in research. In 50 years, there hasn't been a major breakthrough in treatment for asthma or chronic respiratory diseases.
Why is that? And
that's because there hasn't been the investment, there hasn't been the political urgency to make this happen.
Right. The global health community has really rallied around infectious diseases. What can we learn from that response that we might be able to apply to CRDs going forward?
I think effective collaboration. You know, Andrew, earlier this month, on May 8th, we celebrate the 80-year of liberation of Europe.
Yeah.
But that day also, in 1980, the World Health Organization declared the eradication of smallpox. And that was not a miracle. That was a triumph of multilateralism. That was a triumph of collaboration among countries to address one of the deadliest diseases in the world. And I think that time and again, when the scientific community, the public health community comes together and creates a sense of urgency around an issue, resources are found to address them. And the political will to, as well as the public interest to address them, drive the search for solutions and the implementation for effective solutions.
It's possible if we can build that political will. So as in your new role as special envoy, new special envoy role, I should say, what is the one thing you'd want to achieve over the course of the next 12 months? You've discussed a lot, taxing as a finance mechanism, partnerships, raising awareness and political will across the board. What's the big thing on your agenda that you'd like to see achieved?
I think the key is that chronic respiratory diseases have to be integrated into the primary healthcare systems of the countries, because that's where most people will go for their care. I mean, in the panel earlier, they were talking about menopause and also saying that, menopausal care is also primary health care. But that is very important. And investments in primary health care so that the countries are able to address these issues whether it's CRDs or non-communicable diseases or others, is of utmost importance. So if we can achieve one goal is the investment in the primary healthcare system, in the health workforce to deliver that work, and also investment in research and innovation to develop better and more effective treatments to address vulnerable populations.
Well, we'd be very keen to support you in that mission, and we thank you for your leadership and for reminding us that the air we breathe is a global health issue that we need to focus on, and I couldn't agree with you more, and that CRDs may be silent, but your voice is helping ensure that they get a voice. So let us know how we can help you in that cause going forward, because they can't be ignored. So we look forward to seeing the progress that you bring to the issue going forward.
Thank you very much, and I look forward to collaborating with you, with your organizations, as we advance chronic respiratory diseases. If you can breathe, if someone cannot breathe, there is no economic development, there is no education, there is no other goals to address. I think it starts with breath, and I think that for all the talk of equity and these discussions, the lungs are waiting to exhale, so we want to make sure that that happens.
Breathe that in. Jose Luis, thank you so much. Appreciate it. Thank you. Please, right this way. And that wraps it up. Thank you so much for taking the time. A few points I wanted to make. The challenges that we've discussed, obviously, from pandemic preparedness to financing. It's rocking. The architecture of global health. They're daunting. But the urgency of this moment, as I said earlier this morning, if you were here, gives us also an opportunity to think about fresh partnerships and new forms of leadership. So we're going to do that. 4 things that I wanted to ask. I mentioned that there are little green cards on your tables. Flip them over after the agenda. You see, subscribe to FP, QR code. Click through and subscribe and help support us. Attend our events at UNGA this fall. We're going to be doing a lot of health programming. We'll do another Global Health Forum during the UN General Assembly in September. It gets very busy, and there's a lot of people that come to that, so please do register early. We'll get that site up shortly. We're also going to do a simulation on NCDs. So speak to us about that if you'd be keen to participate. And in speaking of participating, you can also partner with us if your organization is interested in focusing on a particular issue that syncs up with FP's priorities. We'd love to talk to you about that. My colleague, Zach Pogowski, is probably out schmoozing right now, and he would be happy to talk to you about that. And I want to thank again our invaluable partners without whom this would never be able to happen: Bayer, NeuroHealth, Seed, Vestergaard, Vital Strategies, and the World Health Summit. And then lastly, please eat lunch. You must be hungry. Thank you for coming.